Happy to be back here, and happy to see all these friendly faces. We've been having a heck of a couple months since the law passed, and we're excited to have our first medical primer presentation. We've been doing a lot of industry discussions, and this is the first time we're actually revealing some of the education information we're presenting to the industry as it relates to cannabis as medicine and some of the physician requirements. So first off, I'd like to thank our partners in helping with this. We've been working for a few months. This is MoCan Trade's Healthcare Education and Training Committee, along with the folks at Healer.com and our partners at Green Fox. And this has been quite an undertaking to bring all this information together. Hopefully you guys find it very meaningful and very useful. First off, my name is Andrew Mullins. I'm the Executive Director of MoCan Trade. If you don't already know, our mission in the industry is basically to ensure a safe, successful, and compliant program implementation. So we're excited that we've got the resources and the professionalism, the credibility of the folks with us here tonight. And I think the way this has all come together, you guys are going to be really pleased with the information that we're going to present. So let me introduce our new presenters this evening. And just by the way, all of our board members are volunteers, and these folks dedicate their time. They are unpaid. So the work that we're doing is really on behalf of the industry, and it's rather altruistic as far as sharing information and education. So I just want to make sure everybody knew that going in. First off, I'd like to introduce Dr. Kyle F. Ostrom, MD, FACP, from Mercy Health, and also MoCan Trade board member, and Dr. Trish Herford, MD, MS, as well as a board-certified physical medicine and rehabilitation specialist. Did I say that right? Wonderful. And also from SOAR Medical and also a MoCan Trade board member. So give it up for those guys, and I think you guys are going to really enjoy this. Thank you.
Thank you, everyone. Good evening. Can you hear me? All right, I'm Trish Herford. I am a pain management and physical medicine rehabilitation specialist. My practice is in Kirkwood. I have an Illinois, Florida, and medical license, and at least since 2015, for me, I have been certifying patients in Illinois for medical cannabis. And so I'll give you that perspective and share with you what our healthcare team has put together as an educational session. Today, Dr. Ostrom and I will go through physician responsibilities, the role of the patient, what they need to do to obtain a medical cannabis card. We'll go through the timeline from the Department of Health and Senior Services. I'll go through qualifying conditions, history of cannabis. We'll get into the cannabinoid systems, dosing, and then we'll talk about current research. So let's begin. This is our disclaimer slide. Marijuana is still a Schedule I drug, which means it's illegal from a federal standpoint. So everything we share with you is what we know up to date. The rules and regulations are still being revised and improved. And if you have any questions, I would ask that you refer to the Department of Health and Senior Services website. MoCan Trade will try and keep that updated on our website as well. Amendment 2 passed with overwhelming support by Missourians on November 6th. And on December 6th, it became legal to discuss cannabis with our patients. And so our role today is to share with physicians who are naive or somewhat scared or frightened by this proposition of talking about illicit substance with their patients and why this may be an excellent choice or option for them. The Department of Health and Senior Services will implement Amendment 2, and they will create the regulations and licensing procedures to put medical marijuana in place as a potential treatment for Missourians who have qualifying conditions. They will impose a 4% tax on all dispensaries for the sale of cannabis products for medicinal purposes. This is on top of all other taxes which would be applicable for business. And that expected revenue is approximately $18 million for the state and $6 million for local governments. What is the role of the physician or the responsibility of the physician? The physician does not prescribe marijuana or cannabis medication. The role of the physician is only to certify that a patient has a qualifying condition which was outlined in the law. Each state has varying diagnoses that are appropriate for qualifying condition, and Missouri has their own set of qualifying conditions, and I'll run through those. So just like anything else that a physician might certify a patient for example, a wheelchair, all a physician would do is say that the wheelchair is necessary, sign the script, and the patient takes that. And that's similar to what would happen with medical cannabis in Missouri. The physician will not be subject to any criminal or civil liability or sanctions for owning, operating, being employed by, investing in any of the cannabis businesses used for medical marijuana in Missouri. In addition, there will be no sanctions or penalties imposed upon physicians for certifying patients who qualify for medical marijuana, as long as they follow the legal standards of professional conduct. To date, one physician has been arrested for dispensing medical marijuana. This was in November in Florida. This physician, in Florida, the laws are a little bit different. You have to have a face-to-face physical examination of a patient, and then you can certify them after you've reviewed their medical records. In some cases, it requires 2 physicians to evaluate the patient. This particular physician did a telemedicine evaluation of 2 patients that lasted less than 90 seconds. One of them actually admitted they had no qualified diagnosis. Unfortunately, both of those patients were undercover DEA agents, so that physician's in trouble, but he obviously was not practicing within the standards of professional conduct. Once the physician certifies that a patient has a qualifying condition, the patient then receives that paperwork. It's up to them to submit that to the Department of Health and Senior Services. The department has 30 days in which to respond, accept it or decline it. The application fee is $25 for the patient, and it requires an annual renewal with a repeat physician certification at that year mark. Once the patient has a registration card saying that they are appropriate for medical cannabis in Missouri, they can take that to a dispensary. The dispensary then will have a patient care specialist who will work with the patients on the dosages, the forms, the frequency of the product that would be most appropriate for the condition for which they're being treated. What we want to reinforce with physicians who participate in medical cannabis certification programs is to have some follow-up with your patients. Just like anything else, you want to know how patients respond when you give them a medicine. Are they better? Are they worse? What worked better for them? This will actually be very helpful when you make decisions and talk to patients about the expected outcomes when using cannabis as an adjunct to their current treatment or to replace other treatments that might not have been so successfully used. This again reviews the certification process. The physician will sign a piece of paper. It's not yet clear whether we have to identify the particular qualifying condition or not, and that will be worked out. The patient will register with DHSS, the Department of Health and Senior Services. They have 30 days to, again, review that application and submit a card. That patient takes that card to the dispensary, and then they'll hopefully follow up with their physician. And the timeline for patients, and I hear this nearly 3 times every day in my patient practice in pain, those applications should be made available online by June 4th. I know that slide says 6th, but the current timeline is, I think, more accurate and reflects the 30-day window. So June 4th, that'll be available. Patients can fill that out. They can take it to their physician. And then within 30 days, that paperwork, after being certified by a physician, needs to be given to DHSS to accept or decline. On July 4th, DHSS can then start accepting those or submitting patients' cards for medical cannabis. What are the qualifying conditions? This is similar to many states. Cancer, epilepsy, which is a seizure disorder, glaucoma, an eye problem, any chronic medical condition causing severe pain or persistent muscle spasms. Multiple sclerosis is the most commonly studied, and there's good literature on muscle spasms and treatment with cannabis. But other diagnoses such as Parkinson's disease and Tourette's fall into this category. Any psychiatric disorder that has been diagnosed by a state licensed psychiatrist is appropriate. PTSD is probably the most commonly studied. HIV and AIDS. Any chronic medical condition in which a prescription medication which could lead to physical or psychological dependence is a potential qualifying condition, particularly if cannabis is a safer alternative. And opioids, of course, with the opioid crisis, are would fall into this category. Any terminal illness, and then the last category gives physicians some discretion. So any chronic, debilitating medical condition, and the whole list of examples here: hepatitis C, ALS, inflammatory bowel disease, Crohn's, Huntington's, autism, neuropathies, sickle cell anemia, Alzheimer's, agitation disorders, cachexia, and wasting syndromes. This is the Illinois application. It's 3 pages. The first column would be the first page. The top half is the patient information section. The bottom half is the physician information section. The physician's name, their practice location. In Illinois, you have to have an established relationship with the patient. So there's a question: how many years have you treated the patient, and when was the date of your last examination? The second column, and those are not a part of the Missouri law. There does not need to be an established patient relationship. The second column is the second page. These are the qualifying conditions in Missouri. They added pain with the opioid requirement in August of 2018. The physician would check any or several of those conditions if the patient would qualify. And the third page is the attestation page, which has the patient's name and the physician's signature. I suspect that the Missouri certification paperwork will be similar with obvious changes based on our laws in Missouri. So what physicians can certify? You have to have an unrestricted license to practice medicine in Missouri. So MDs or DOs. Assistant physicians, which is a new term I didn't know about until just recently, cannot. Assistant physicians are people who have graduated from accredited MD and DO schools but have not finished residency. Physician assistants, which are different than assistant physicians, cannot. So PAs are unable to certify patients, and nurse practitioners or NPs cannot certify patients in Missouri. Here's the timeline. December 6th, the law went into effect. January 5th, you could start accepting fees. June 4th, application forms and instructions will be released to patients to complete and have paperwork completed by a physician. And July 4th, DHSS will begin accepting those applications and rendering opinions. Facility license applications, not fees, will begin August 3rd with approval for those applications at the end of December. So, brief history of medical cannabis. I suspect all of you in this room have some interest, but I find this part fascinating. Cannabis has been around for 12,000 years. Probably started in Asia based on historical records. Spread to Egypt and India. By the 1800s, 2 physicians, an Irish physician, Dr. O'Shaughnessy, and a French physician, can't remember his name, I'd probably crucify the French anyway, that French pronunciation, brought cannabis to the Western world. There is written histories suggesting that Queen Victoria actually used cannabis for menstrual cramps. A Lancet article was published in the mid-1800s by Dr. J.R. Reynolds, who touted the wonderful and multiple great effects of cannabis for conditions such as malaria, constipation, absent-mindedness, female disorders, and a variety of other things. AMA physicians and physicians in general really recognized this herb as a benefit in treating their patients, and it was well utilized and well used. And in fact, the third edition of the U.S. Pharmacopoeia, which lists all medications, included marijuana at that time, including how to prepare product for use in your patients. In the 1900s, the Marijuana Tax Act happened, and I'll get into a little bit more detail. There was a significant propaganda machine against marijuana, and the cannabis product was removed from the 12th edition of the U.S. Pharmacopoeia at that time. Dr. Raphael Mechoulam was a physician from Israel who's thought to be the father of cannabis, and he actually isolated the Delta-9 THC product, and soon thereafter identified CB1 and 2 receptors. And a lot of research began on this wonderful system that now can be used to treat disease, which Dr. Ostrom is going to enlighten all of us with. The Compassionate Care Proposition 215 in California passed in 1996, and Washington and Colorado followed in 2012, with Missouri following with medicinal cannabis just last November. The Marijuana Tax Act effectively prohibited marijuana use amongst patients in the United States, and also limited the physician pharmacy distribution of cannabis for any ailment. There probably was a lot of political influence here, as these powerful families who were in charge of plastics and oil at the time found industrial hemp to be a significant competitor to their product. So the Rockefellers, the DuPonts, the Carnegies, the Mellons, the Hearst, yeah, for sure. It's right there. So in 1970, the DEA, in the early 1970s, the DEA was created, and they began a schedule system, and they placed marijuana in a Schedule I drug classification, which for people who don't know that means there's no medicinal use, that the potential for abuse is extremely high. LSD and heroin are other Schedule I drugs, and marijuana was placed in that. So this prohibition of cannabis has been around. And through history, including right after the 1937 time period, physicians have, some physicians have thought that. In fact, the biggest proponent against the prohibition in 1937 was the president of the AMA at the time, Dr. Woodward. So unfortunately, propaganda and money overpowered the potential benefits and use of cannabis in the 1930s through our present time. This is touted by a lot of people as to the discrepancies between the scheduling of cannabis as a Schedule I drug and what the U.S. government really thinks. The U.S. government in 2003 took out a patent on cannabis, knowing that cannabinoids actually had a neuroprotective and antioxidative effect, that they wanted to hang on to that patent, and they've kept it going. So, for a medication that has no potential use and high potential for abuse, our government has actually patented that for some particular medicinal use. Medical cannabis has been approved and is legal in 32 states now. Recreational cannabis in 10 states, as well as the District of Columbia. 89% of patients in America support legislation which legalizes medical cannabis. And interestingly enough, 69% of physicians, although 69% of physicians or somewhat an elevation of the number of doctors who actually feel comfortable certifying patients for medical cannabis use. That's changing. Many medical schools are implementing educational programs looking at the cannabinoid systems for treatment of a variety of disorders, and how to effectively instruct patients on the use of cannabis from a pharmacologic standpoint. Marijuana facilities. So what happens to the product? First, it needs to be grown. So the cultivation of the plant, the drying, curing of the plant is done in the cultivation centers. There'll be at least 59 based on population in Missouri, with those numbers to be determined by DHSS. Manufacturing facilities then take that and make a true product out of it, including the oils and tinctures that would ultimately go to the dispensaries. Again, this is population-based, and likely that to be in the range of 85 manufacturing facilities in the state. Testing labs actually look at the product for any contamination or any pesticides. They'll also look at the strength of the product so that that can be labeled and given that, and we'll give that information to labs so that that can be passed on to the consumer or the patient. And then the dispensaries, which will sell the product. Again, they'll go over the form, the strain, the frequency, and the dosage patterns for patients based on their health and their medical condition. All right, I'm going to pass this along.
Good evening, everyone. So the next part of this presentation is going to be fairly scientific, if I was to say it. So I think originally this was directed at practitioners in the world of medicine with some basis for how the science behind cannabis works. So to start with, our bodies work on a complex series of signaling. And part of this signaling is done by receptors. The interaction between particles and these receptors, whether it's inhibition or excitation, determines the cascade that follows, and usually a feedback loop from there. That's primarily what we'll talk about in the endocannabinoid system. So this first wheel is nice. It's a simplified approach to the clinical effect of receptor stimulation. So I'm going to stand in front of this, unfortunately, but it's broken down by body system. Then it's broken down by some of the 60 plus known phytocannabinoids. Those are the compounds found inside of cannabis that have some medical effect in the body, or say medical effect, some effect in the body, some receptor stimulation. And after that, the disease state by which they exert their effect. This is my busiest slide. I also think it's the most important. So the last slide showed the end result or the clinical result. The way we get to that clinical result is where that receptor is stimulated. If you look at this slide, you see CB1 and CB2. We'll talk about this. On CB1, you notice there's a concentration in the brain and the central nervous system. CB2 tends to be in the peripheral tissues. It also includes the hematopoietic tissues. That's your bone marrow that produces immune system, red blood cells. And so the stimulation of those receptors or the inhibition of those receptors is going to occur in those particular body sites. You'll see on there it lists THC, cannabidiol, and cannabinol. So we'll talk about those three. Again, there are 60 plus identified phytocannabinoids. So a little bit of context to this. She mentioned Dr. Meshulam, Raphael Meshulam's a PhD bench researcher in Israel. In 1964 was the first to isolate delta-9 tetrahydrocannabinol, which is the only psychoactive compound in the entire cannabis plant. It wasn't until around 1967 he realized that only the L isomer is active, the R isomer is not at all. But backing off, coming from that research, knowing that these two compounds were in cannabis and that they had some sort of effect in the human body, the question was, where do they have their effect? So the second part of it was the discovery of the receptors CB1 and CB2, which I think is the most interesting. So that was discovered by Dr. Howlett. Her lab was at St. Louis University here in St. Louis. There's a question of whether or not it was discovered in sort of the mid-'80s to the early '90s. The first time she discussed it was in a review paper in 2002. At the time, her lab was actually working in conjunction with Pfizer, and so a lot of the information was delayed because it was proprietary to their company. Shortly after the discovery of the two receptors, then the question was, what is stimulating these two receptors? So we're aware from the world of cannabis of phytocannabinoids, which is the exogenous substance that you give yourself. So what is the endogenous system? Why does the human body have these receptors to begin with, unless we already produce something that stimulates them? And the answer is we do. So there is what we call mimicry molecule, so a molecule that's very similar to THC called anandamide. I believe it's either the Israeli word or is it the Latin word for bliss, ananda. Anyways, anandamide, which is the human mimicry molecule or endogenous molecule, and then 2-AG, which is CBD. So the question is, what else is out there? The answer is we don't know. But we know for a fact that these two endogenous molecules exist and that they function very similar to both THC and CBD. If you look at the phytocannabinoids, the 60 known, or 60 plus known, each one of them is going to stimulate the receptor in a little bit different way. More towards CB1 or more towards CB2, more selective. There's none that is wholly selective, I should say. These are the 3 currently approved drugs in the United States. There have been multiple cannabis drugs approved outside of the United States. The first one is dronabinol or Marinol. That is a synthetic THC. So it is structurally it's THC. It's just bench created. The second one's Nabilone. That's a wholly synthetic cannabinoid with the goal in vivo to produce the exact same effect as delta-9 THC. But it is, again, it's wholly synthetic, so it's a little different chemical. And then the last one, you're aware of the most recent FDA approval, and it's for a CBD solution. And this is actually a plant-based solution. So of interest, again, we go through, this would be hours long, but receptors that are outside of the standard treatment now, CB1 itself, if literally just excited, not inhibited, on its own, somehow or another, seems to weaken the appetite and causes weight loss. So Sanofi Aventis actually developed a drug. It had 2 different names. Rimonabant was the non-trade name for it, but it was released in Europe in 2006 as a weight loss drug, and it worked. In post-marketing surveillance, about 10% of patients ended up with depressive symptoms, and some had induced psychoses, which is why it got pulled from the market in 2008. But moral of the story is that we see these 3 FDA approved right now, but there are a whole host of them approved in other parts of the world and have been. And if you look back, look, I mean, dronabinol was approved in 1985. So again, this is not new news, if you will. So these are the phytocannabinoids. So we have 2 endocannabinoids, the 2 substances produced by our body that stimulate or inhibit the receptors, and that is anandamide and 2-AG. And then you have their mimicry molecules and a whole host of ones that maybe we do make endocannabinoids that are part of this, but unfortunately we have not isolated those yet. What is interesting, actually, so THC, I told you, is sort of an equal stimulation of both CBD1 and CB2. Equal stimulation of CB1 and CB2. Anyways, CBD actually does not stimulate or inhibit either one of them. It actually has 0 effect on the receptor itself. There's some question about whether or not it slows down degradation of your endogenous anandamide. We're not sure exactly how it works with the THC. So classifying cannabis had to change based on this, because originally when you classified cannabis, it was determined by the plant that it came from, but no longer is that appropriate, since we know that there are actual receptors in the human body, we know there are other compounds, endogenous compounds in the human body, and so naming it, it's like wine. You buy French wine based on the region it's grown, and in America or Australia, you buy it based on the grape it comes from. So newest labeling involves THC to CBD ratio, or sometimes what other of the cannabinoids end up in the product. Industrial refers to anyone that has less than 0.3% THC. Cultivar refers to the strain from which it came, and the chemovar refers to the chemical composition of it. So CBD is an allosteric modulator of this. So in layman's terms, it helps determine how the THC actually functions. CBD in clinical trial has been shown to completely mitigate the side effects or psychoactive effects of THC. So again, we talked about what it does in terms of inhibiting the degradation of anandamide. We're not sure how it affects THC. Clinically, it can mitigate the side effects of it. So many patients choose different ratios when it comes to CBD and THC. So you have daytime increased CBD dosing to decrease the amount of sedation or psychoactive effects of it. Perhaps in the nighttime, you're interested in more sedation, so it is typical for patients to end up on more than one product at the exact same time. A patient who has a seizure disorder, you may end up with 2 or 3 or 5 different seizure medications, so this is not unheard of. The only caveat to all this is as you increase the CBD dose, you're increasing the total milligrams of whatever product that they're consuming, which also increases the cost. So this is a sample form for laboratory testing. There are often questions about how pure is the product that you're getting. The laboratory testing in the state of Missouri is all going to be certified by DHSS, so you get CLIA certified as a lab. This is what the form will look like. They're tested obviously for adulterants, that includes pesticides, but it also includes the actual chemical composition, including terpenes. So terpenes are interesting in that every plant has terpenes. They're volatile, unsaturated hydrocarbon. They're found in the essential oil of every plant. They're especially concentrated in citrus and conifers. They are what makes your plant smell or taste. So why does a lemon taste one way and an orange taste another way? Dependent on terpene. What's also interesting about terpenes, of course, is they're going to change the composition, the smell and taste of the product that you get in the oil of cannabis. There is an entourage effect, and I think what's interesting about this is it reinforces the idea that we have multiple different receptors. So, since the mid-80s, early 90s, when CB1 and CB2 were discovered, there have been gene polymorphisms also discovered too. So there are people that produce a different kind of CB receptor. So don't expect one person's effect with that particular drug to have the exact same as the next person's. CB1A and CB1B both decrease expression of messenger RNA, meaning that their downstream effect is much different, much lower than sort of the average cannabinoid receptor. So again, don't expect one person's experience on a medicine to be the exact same on the next, and like I said, there's a clear reason for it. The dosing for cannabis is a bit tricky in that there is no standardized dosing for it. You go to the store and you buy Claritin, it's 10 milligrams every single time. The thing about Claritin is it has an extremely large, what we call therapeutic window. That means that you take a very low dose of Claritin, it does nothing. You eventually get up to a dose where it does something. And then where's the dose where you overdose on it? In the case of Claritin, that window is so massive that it's safe for just about anybody, which is why it's over the counter. In the case of cannabis, we don't have a therapeutic window. So what you have to do is you have to titrate up that dose. You start low and slowly get to the dose that is most effective for your patient. I would say for those practicing in the room, this is akin to like you start something with gabapentin for neuropathic pain or methotrexate for their psoriasis. Then these are drugs where you start very low and then you retest until you find the dose that's correct for the patient. There's a bidirectional effect. Again, this would make sense. 10% of people much higher in toddlers are hyperactive on Benadryl. The other 90% of us all fall asleep when we take it. So don't expect when one person comes into your office and says to you, my neighbor Joe takes whatever, and this is his experience on it. There's no guarantee that that's the way. As I said, we also don't know what we don't know in terms of the receptors still out there. The best dosing practices are going to be determined upon the ingestion of it. I think really what this is trying to show, laser. Okay. So the liver has something called first pass metabolism. So anything that you ingest orally makes it through the liver once before it ever makes it to your bloodstream. And because of that, there's some amount of that, whether it's a prescription medication, cannabis, doesn't really matter. There's some amount of it that's going to be either inactivated or removed completely. So less of which get orally. For anybody out there who's ever seen testosterone, there's no pill for testosterone. It is completely eliminated by the liver. So you have to take a shot or a cream or a gel or something. It has to be taken into your body by some other way than through your alimentary canal. So this is PK or pharmacokinetics. This will tell you about how long it takes for something to get into your system, how long it stays in your system. I think, again, what's interesting about this is when you find people, we're treating them for pain management, or if you're treating them for anxiety. They may be on a prescription medication they take every single day to help prevent anxiety, but they may also have breakthrough anxiety. And those people, they have a second medicine that also helps to quell the anxiety. In the case of cannabis, you'll find the same thing. People will take and ingest it, and then they may need something for breakthrough and use an inhalation form. This is important in that Missouri has, as part of the amendment, the ability to have home grow. So you can certify a patient for home grow, so they grow their own marijuana. The question is, what do they do with it afterward? Well, most people don't own a massive facility to be able to process what they've grown at their house, and so a lot of patients will choose juicing. What's important, at least from the medical standpoint, is that you're going to have a much slower time to action and a much longer time of action. The other thing is, as you see, there's a comment about there. So you decarboxylate THC when you smoke it, so you're going to have a dramatically different effect from smoking it as opposed to vaping it or, again, another ingestion method. These are non-standard dosing recommendations. I think the takeaway from this is that you can start at a lowish dose and know that a person who has more fat cells, all of the phytocannabinoids are lipophilic, meaning that they bind to fats. So somebody who is larger will tolerate a larger dose to begin with. But generally speaking, you're talking about increasing this very slowly, titrating to the most effective dose. There is a nice resource. It obviously is a national website, but their administration is based in St. Louis. They do individualized patient plans, so patient or doctor accessible. You have a patient you prescribe to, and they want to be able to go through an individualized plan and get recommendations on, if they start getting side effects, how to mitigate those side effects. And it was a completely free, absolutely fantastic resource. And then also, I thought pretty interesting. So with any drug, you go to the pharmacy and it says, don't take within 2 hours of eating, or take a bed or whatnot. So the same is going to be true of cannabis. Your other activities are going to alter the pharmacokinetics of this drug. Most interestingly is, after the CB1 and CB2 receptors were discovered, and they needed to figure out what compounds were stimulating these receptors, they did these radio-labeled studies where they literally took all kinds of endogenous substances, they labeled it, and then watched when they got stimulated which one went to this receptor. So one of those is the anandamide, like I said, specifically stimulated during cardiovascular exercise and is implicated in the so-called runner's high. So believe it or not, your cannabis is probably giving you your runner's high. There are a bunch of known interactions. For those in the room in the world of medicine, the known interactions are what we call standard interactions. Medicines like rifampin that induce the cytochrome P450 or CYP450 system. This is your liver's ability to inactivate and excrete substances. So inducers of that system are things like rifampin. What they do is they speed up your liver's ability, meaning that if you're on a medicine like that and you take cannabis, your cannabis effect is going to be either less potent or less long. And then there are medicines that also slow down the liver's processing, and those are like azoles, fluconazole, commonly given for yeast infections, toenail infections. So those kind of medicines are also going to slow it down, meaning there's going to be an additive effect. And then last, but certainly not least, in terms of medicines that are going to interact, so we call these like synergistic effects. Let's say that you're on a medicine, like a sleep medicine, but you also take Benadryl, which makes you sleepy. The two together are going to make you doubly sleepy. If you're on cannabis that causes some sedation, medication that causes sedation, the same thing's going to happen. So the rest of the medicines on that list are those kind of medicines as CNS depressants. To date, this is the largest collection of clinical information in the world of cannabis. And it is, it's peer-reviewed. There is no quote-unquote pure science, and these are all clinical studies. Sometimes as small as 15, sometimes as large as the Minnesota study, which had 6,000 in it. So it's not nothing, to say the least. This is the expert distillation of it. So if you want to know what their recommendations and why you see a lot of the laws so far, the 32 that have medical cannabis, why the qualifying conditions are there, it's based a lot on the Green Book. One of the things to note in this is that, as you guys saw, like I said, Dr. Howlett's paper got published in 2002, and then the republishment in 2005. It's 2019. So if you're going to design a study, and it's going to be a placebo-controlled, randomized trial, and you have to enroll patients, you're talking about 2 years of getting through the institutional review board of medical school before you finally get approval for it. Then you have to enroll patients, you have to get funding, this and that. You're talking about 7, 8, 9 years before something comes to publication. And in the middle of that 7, 8, 9 years, well, another phytocannabinoid gets identified. Another polymorphism in a gene that creates a different receptor gets identified. And now all of a sudden, the premise behind your study is no longer valid. So what we end up having to do is have these massive, these like amalgamated studies, these tons and tons of patients, and afterward we do something like post hoc analysis, subgroup analysis, where you try to divide amongst either a disease state or an outcome or whatnot to try and figure out why it became the way that it did. And then I'm going to turn this back over to Dr. Herford to let her talk about cannabis and pain.
That last bit of information is a free download, and if you're like me and you don't have time to read 440 pages, pages 13 through 22 will summarize everything you need to know from that document. So, pain is the number one reason patients are certified for medical cannabis, and there's plenty of research out there based on different types of pain. Specifically, with the Missouri law, migraine, intractable migraine, fibromyalgia, which is a centralized pain disorder that's chronic and can be severe, cancer-related pain, of course, pain from neuropathy, which is a nerve disorder, arthritis, rheumatoid arthritis, even osteoarthritis, which is the normal degenerative arthritis that many of us suffer from as we age. Spinal cord injury is a neurologic disorder, but oftentimes leads to severe pain related to spasticity or spasms. Stroke-related pain, again, you have a central pain disorder. It starts in the brain, but affects the extremities. And PTSD, as well as the psychological pain disorders with other psychiatric illnesses. So this is a big player in treating patients or giving them options for better control of the most common symptom for which patients present to a physician. These are some of the dosages based on research that have been effective for different conditions. And I won't go through those. I will just share with you that every patient, every person is different based on their age, their genetics, and their medications are on, and multiple comorbidities, whether they have liver problems, heart problems, or lung problems. But these are just some examples based on research. The medicinal benefits, of course, we've been through, helps with seizures, improves pain, can limit anxiety and psychological complaints related to PTSD, can reduce intraocular pressures and glaucoma, and it actually is a fabulous sleep aid, which in the world of pain is a significant issue. It's less addictive, and in fact, it's been documented that patients who are placed on cannabis have a significant decrease in opioid consumption, and with the opioid crisis, this is really important. And in my personal practice, I find this to be quite true. I've been able to eliminate opioids or significantly reduce them in most of the patients that I've certified for cannabis in Illinois. So this is just a summary, and we're going to open it up for questions. Patients should start low, start with different strains, work with the dispensary specialist, the patient care specialist, in finding their doses appropriate for them. I would encourage a feedback loop with physicians so that you can share the experience of your patients with other patients in order to better serve them. If there are any questions, certainly go to the Department of Health and Senior Services for further information. Again, we'll try to keep that updated on the MoCanTrade website as well. Healer.com is an excellent resource for patients as well as physician education. Thank you. Yes?
I noticed that the rate or the percentage that you had going from opioids that were helped off of opioids by cannabis was relatively low, about 5.8%.
Reduction of 5.8% on average based on that study.
So do you think it should be higher and it's just not been an option for folks, or is it, just the physicians are not familiar with the effects, so they keep people on opioids? So I guess what do you think?
So as a pain management physician, there's a lot more that goes into the treatment of patients with pain and the use of opioids, that there is a significant psychological dependency. It is very difficult to eliminate opioids entirely. So it's a very slow progression. I suspect that the opioid elimination and reduction is more would be more successful if that was a criteria for cannabis, medical cannabis use. However, given the difficulties in reducing opioids in patients who've been using them for sometimes dozens of years, that takes a lot of work and a lot of time on the physician's part, and may be a reflection of effort rather than true statistical findings. I will share with you that part of my role with patients is to encourage activity, and with cannabis, it is a definite trade-off. The reason we're trying medical cannabis is because opioids haven't been effective enough, and so many of those patients will remain on opioids, but the goal is to decrease them, and we do, and I've been quite successful at that, much more than that 5.8%. Yes?
Just curious, I've got a little bit different perspective. I love all the pain, what you're going into, but it also, in my field of looking at it from a personal point of a family member, that what I've found is it's curing cancer in the brain. You know, we've got someone who has brain cancer, and it's decreasing those cells to shrink the brain tumor, and I wonder if this is something that you come across. But I know St. Louis University is out there doing with kids, and you know.
There's certainly evidence. If you'll go back to that National Association Press document, there is some information there from research that's been looked at. And again, I will share with you that U.S. patent really looked at the improvements in neurodegenerative diseases with one of the perspectives on cancer reduction.
So there's no good data in humans yet. In mice, when they apply specifically CBD, although they tend to end up being more than one chemical at the same time, somehow or another potentiates or increases synergism with the chemotherapy applied, meaning they give a drug and you can give it in lower doses with less toxicity and more killing power. This is not true across the board for every single kind of cancer, and again, as we understand cancer better, the genetics behind it, again, if a particular cancer cell doesn't express the receptor for the drug you're about to get them, it's a worthless drug, whether it's cannabis or it's chemotherapy. But I think it's a burgeoning field, to say the least.
I feel like I've come across quite a bit of studies that have shown a lot of studies where there is a decrease in brain tumors themselves. So that I'm curious if you guys, coming across it as well.
Yes.
Right. Typically, if you wanted to get a new indication for a drug, you go to FDA and get a waiver. How do you deal with that?
So from a research standpoint, therein lies the biggest issue. You have an investigational new drug application. You have to get it approved by the FDA. The National Institute of Drug Abuse has to get involved because we're dealing with marijuana, a restricted substance in the United States. That has to be reviewed by the DEA with approval given, and then it has to go through the IRB, Institutional Review Board, for if you're working with human subjects. So the process is extremely difficult. And the other problem has been the product that has been supplied up until just recently all came from strains out of the University of Mississippi. Now, since medical cannabis has been legalized in multiple states, they are much more open at the University of Mississippi through NIDA in finding and utilizing plants that are much more compatible with the strains that are being used in states now for treatment of medical conditions. Yes, sir.
I just wanted to make sure I heard correctly. So on the dispensary side, from the regulatory standpoint, is it going to be mandated that a care coordinator is like in the dispensary?
I don't believe so, but I'm going to leave that to Andrew to answer.
I believe it's still to be defined in rules and regs. Jack, you can jump in there too.
I think it's a suggestion that at least one person is trained and certified within the facility.
Yeah, so in the actual amendment, Amendment 2, and Missouri Constitution, there's no requirement for that.
Okay.
But the Department of Health, over the next couple months, will promulgate their rules and regulations. It's one of the things they're looking at.
Okay.
And certainly, when people go in August to make application for dispensary, it's one of the things that obviously could set them apart from other applications. So there is some creativity here that you're going to see from applicants, but you also have the Department of Health providing some guidance through rules and regs.
That's cool, because I was just going to say that, like, I think that, you know, oddly enough, in terms of the conditionality aspect, you know, that this might actually yield because the data will be close. Like, you know, some of the conditionality things that actually, like, may not be accessed through the path of the FDA and, like, some of the lobbyist stuff. So, and then obviously you have, like, the social determinants of health, like that whole issue too. So I'm interested to see kind of what plays out with that, because that, you know, could be kind of an unforeseen positive outcome of some of the stuff too. So
a question for Jack. This patient care specialist is going to handle the dosing. Has the Department of Health thought about like the type of training that this person gets? Like, where do they get their training, and why is the physician separated from deciding on the dose when usually the physician says, okay, we start with this dose? So it sounds like it's been handed off to somebody else.
Yeah, and that is the exact pattern. What you see, what you described there, is in the other 31 states. That's where it happens. The doctor, because of course it's federally illegal, the doctor's just making a certification, not making a prescription or prescribing per se. They're just making the certification. They meet the guideline needs, and then it's really on the dispensary side where you see more of that. So it is very different than what we see in other medical fields.
So as prescribing physicians, I would suggest to you that when these dispensaries are there and you're going to be a certified physician, that you know what your dispensary, how well they're trained. I think that, you know, you want to know that. I will, and I suspect that dispensaries are busy because physicians trust that they're giving good product and good recommendations to patients. Will soon be followed by other dispensaries raising the game, doing the same thing. But it is important for us, I think, to know where you're sending your patients.
So who trains the patient care specialist? Is there anything set up already, or like they just say, hey, I'm going to be an expert? Where does that training come from?
But if you think about the retail side of it, I think there's some obligation, and it's incumbent upon the folks that are operating the retail organizations to elevate their knowledge, elevate their training, and that's why we provide some of the, you know, the healer documentation and certifications, and obviously there's other resources out there, but all that, when you think about that feedback loop, that experience, that retail experience, is going to be played back to the physicians when you go back, whether to get recertified or you just go back for a regular checkup. And hopefully, you know, the people understand the difference or experience the difference between a quality patient care type experience versus more of a, you know, just putting something over the counter. And we feel like the criteria that the department's looking for in their scoring of applications will sort of not require, but encourage the best possible retail experience with training and knowledge and certification.
So there's no standardized training for the patient?
There's no requirement for standards.
Jack, you can back this up. I asked this question a while back. I don't believe there is one nationally. Like, there is, at the retail level, there is no requirement for a certification for medical cannabis dispensaries in any state. Is that true?
There is, in Washington State, they do have a program that's run by their Department of Health that where employees of the dispensary do have to essentially take some type of testing or whatever. I know that's something the Department of Health is looking at right now. I'm not sure if that'll be in the rules and regs or not.
And obviously, from the sort of physician-patient continuum, we're supportive of that. We want this to be the best experience possible, so the physicians have confidence in, you know, in the fact that they're only certifying, but that what is happening on the other end that they have no control over is hopefully a quality experience and helpful.
There's a green hands in the back that have been held up. The woman in green.
Yes, that does make me a bit nervous as a primary care provider, because we certainly haven't had that.
I don't know, policing or standard, when you talk about the supplement industry or anywhere else that my patients can go in to go to a testosterone clinic or to go to take their supplements from GNC. So I would like to have defined if there was some sort of medical licensure or training, feel a lot better if it was physician-led, pharmacist-led, those things at the dispensary. And then my follow-up question to that would be, what is going to be the feedback to the physician from these dispensaries when you decide what types of product, what dosing? Because if it's my responsibility to make sure I'm keeping my patients safe with regard to other interactions and side effects and things, we're going to need some flow of communication that's very clear.
That's clearly where that feedback loop as a physician becomes important. I will share with you, it's kind of like for physicians in this crowd, sending your patient to physical therapy. Oftentimes you don't identify the physical therapist they go to, and some therapists are awful. And you don't send your patients back there. It's the same thing, especially for physicians who are new to this. It's really incumbent upon them to, I think, know your dispensaries and know that there's some training. That's a simple phone call. Find out. There are ways to ensure that the reputable dispensaries have the tools in place and the education of their employees to help your patient. The dosage and strength of the product will be available. Your patient just has to be able to share that with you. And then again, it will vary. You're not going to see a standardized, it's not going to be as simple as just getting, this much in the tincture form will cure this problem or help this problem for all your patients. So you really are going to be more actively involved in this product with regard to helping your patients.
Yes, we have time for one last question, so whoever's got the...
How does Missouri's format differ from other states? Like other states have prescription formats where the physicians actually dictate the dosage and dictate the frequency and all that. So what number of states actually have that format as opposed to what Missouri's
Florida
format?
has that, but only because I'm licensed there.
Utah
does as well.
Well, they're currently going through their regulatory process.
So how many states actually is following Missouri's format or proposed format?
I suspect the majority, and I'm not sure. I think the majority. Again, there's no one size fits all with cannabis for medical conditions. So it's hard, even in Florida. Physicians, we have to go through a training process. But those dosages and those dosage patterns are really just a guideline for starting low and building up slowly, which is the same philosophy that we're suggesting here.
Hey guys, thank you so much for joining us this evening. We have plans to do this again. We're looking at dates and locations in Springfield and Kansas City. As a trade organization, we know how important it is. We don't want to lead the conversation, we just want to start the conversation so physicians, practitioners can get the information, education they need and dig in further, because this is very important to the health of Missourians. And thank you again.